So let's start the class without wasting. I hope they will see on Gmeet, or they can later on view in Ekalavya. Okay, so I'm Dr. Bhuvaneshwaran. This will be a very informal class only. It's just going to be discussion. I won't ask any questions. I promise you that. Except when the questions come, it will be in the last or during the last slides. The moment question comes, it's thank you only. Okay. So it's an overview of posterior uveitis. It's a very vast topic. So what is uveitis? Uveitis is inflammation of uveal tract. Uveal tract includes from front iris, ciliary body, choroid, and then the entire thing. Okay, so the entire eye cord starting from front to back. So when inflammation happens, it can anterior chamber, in the water in the front of the eye, or in the vitreous cavity, which is in the gel in the posterior part of the eye. Okay, so classification, we classify uveitis into anterior, intermediate, and posterior. Anterior in front of the lens, intermediate in the ciliary body, ciliary processes, and in the front of the front portion of the vitreous, which is in the anterior vitreous phase, and that is intermediate uveitis, and posterior is anything behind. So posterior uveitis, it can happen. So uveitis per se, you call it, as I said, it is inflammation. Inflammation, how do you explain to the patient? When patient comes and says, see, is it infection? No, it is not infection. It is inflammation. What is inflammation? I explain to the patient in these words. Like in actual particular language, in Tamil, Telugu, Hindi, Malayalam, you call it Vikam. Vikam. In Hindi, you call it Gadia. In Bengali, you call it Bad. If you have to explain further, when you have an injury to any part of your body, there is swelling. This is inflammation. When there is inflammation, the surrounding places also there will be some amount of inflammatory spread. So uveitis is also the same. When you have trauma, inflammation happens. But uveitis is mostly trauma without any, means inflammation without any trauma. So it is an abnormal inflammation which happens without any trauma. So in posterior uveitis, what all, I hope anterior and intermediate uveitis classes has been covered, so it is not my topic. I am going to only talk about posterior uveitis. So what all is there in the posterior part of the eye? You have retina, you have choroid, you have the vessels in the retina, you have the optic nerve head, which is the optic disc, and any ocular coat which is behind the lens. So in posterior uveitis, you can have all this. You can have retinal vasculitis, which is inflammation of the retinal vessels. It can be artery, it can be vein, it can be anything. Retinitis is inflammation of the retina per se. Choroiditis is inflammation of the choroid per se. Retinochoroiditis, inflammation involving both the choroid and retina. Neuroretinitis, inflammation involving the optic nerve head, which is the disc edema, along with some portion of the retina. Posterior scleritis, which is inflammation of the sclera coat, which is in the posterior part, posterior sclera. So this is all can be bracketed under posterior uveitis. There is something called as pan uveitis as well, which is VKH, sympathetic ophthalmia, Behcet's, which also has a which is pan uveitis classically, but it also has a posterior characteristic posterior inflammation, which can be called as posterior uveitis. So it can be etiologically classified into two: infectious and non-infectious. Infectious, you have tuberculosis, Toxoplasma, Toxocara, TB, syphilis, Bartonella, which is cat scratch disease, viral, HIV, and non-infectious, you have a entire white dot syndrome, everything which comes under white dot syndrome, which is APM, PPV, mutes, multifocal choroiditis, pigmentary inner choroidopathy, birdshot choroiditinopathy, and you also have other autoimmune things like SLE associated, sarcoidosis, all these things. So investigations, in Uvea, even if you are posted in Uvea, the two things that you will see is our list of investigations will be a wide range of investigations, and it will be both ocular and systemic, not ocular alone. So In set of ocular investigations, apart from slit lamp photo and fundus photo, where we want to document what is there, we also write OCT and OCTA and FFA and ICG. FFA and ICG are invasive procedures where you inject a dye to see. These two are by separate itself two different classes, but FFA is something where you is an investigation where you put the dye to see the retina proper per se, and ICG you see lesions in the choroid proper per se. Okay, so OCT and OCTA, you would have seen people writing SD OCT, SS OCT. SD means spectral domain, SS means swept source. So these are the OCT. It is just like telling it is LED TV, it is HD TV. So the quality of the picture, whether it is spectral domain OCT or swept source OCT, which is the more clearer version. Systemic investigation, blood investigation, urine, stool, imaging, we have chest X-ray, CT, MRI. We have a set of investigations through which we try to diagnose what is the problem for the patient, but we do not investigate everything. We do a tailored set of investigation. Okay, so we will talk about one thing step by step. So first we will talk about retinal vasculitis. Vasculitis is what is, we have both arteries and veins in the posterior pole in the retina. So which is more common? Periphlebitis is more common than periarteritis. Okay, so the most common retinal vasculitis in India is said to be Eales disease. So this picture is a classical picture of Eales. So if you see you have vascular lesions in the mid periphery. The vasculitis lesion in the mid periphery in in more than one or two vessels, and you have hemorrhages surrounding it. Okay, so Eales is the most common thing in India. And what other things can have retinal vasculitis? It can be associated with other uveitis, other collagen vascular disorders, other infectious diseases, and other neurological diseases. If you look at the first picture, you have this is a classical retinitis. Okay, so surrounding the retinitis, you have some parts of the vessels which are inflamed and there are hemorrhages. So this is retinitis, the vasculitis associated with retinitis. If you look at this picture, you have choroiditis lesion and you have retinal vasculitis surrounding that lesions. So this is choroiditis with the surrounding vasculitis. And so here you have something called as Eales arteritis. So this is a Toxoplasma retinochoroiditis with an associated retinal vasculitis, so which is called as Eales arteritis. Probably you must have read it during your PG preparation. This is a picture of sarcoidosis where you have candle wax dripping, and this is classic. There are a few places of vasculitis. You also see in other collagen diseases, say for example in SLE, you can have retinal vasculitis. Neurological diseases, multiple sclerosis, you do look for retinal vasculitis. So in retinal vasculitis, the history goes like this. Initially there is inflammation, followed by which there is ischemia to a peripheral part of the retina, followed by which because of the ischemia there is neovascularization, and because of the neovascularization there is fibrovascular proliferation. So in Eales, there are two important studies which are done in our hospital. So one, they did histopathological and immunochemical studies from enucleated specimens from cases of Eales disease, and the second study is basically they did PCR to detect Mycobacterium tuberculosis from vitreous samples in Eales. So both the study actually concluded that Eales is basically a cell-mediated immunological reaction triggered to Mycobacterium tuberculosis antigen. Okay, so Eales, it was discovered by Henry Eales in 1879, but the reason being more tubercular and the tubercular associated, it is a cell mediated reaction. It came way later in 1999. So when do we suspect tubercular uveitis? When you have retinal, so this is the same picture which I showed you before. When you have choroiditis associated and with the surrounding retinal vasculitis, you suspect tubercular uveitis. When you have choroiditis, see, these white lesions are underlying the retina, underlying the blood vessels. So these are in the choroid. So these are, you have not single foci, you have multiple foci. So these are this is called multifocal choroiditis. This is subretinal abscess. This is a choroidal nodule. Okay, so when you have these characteristic features, you suspect tubercular uveitis. What do we do in case of tubercular uveitis? We do manto, quantiferon. We do manto, quantiferon, chest X-ray or HRCT. So with these 4 investigations, when 2 of the 3 or 4 investigations comes positive, we consider it as presumed ocular tuberculosis. Okay, so of what 3? So chest X-ray is usually not the choice of our investigation. We do manto, quantiferon and HRCT. 2 out of the 3 is, when it comes positive, it is called presumed ocular tuberculosis. When you have an AC tap or a vitreous tap done for PCR for MTB, and when it comes positive, we call it as confirmed ocular TB, because we have a PCR which confirms the disease. So both presumed and ocular TB, we take an opinion from the pulmonologist, and we advise, we judge and we request the patient to start on ATT. So if you have seen the older ATT regimens, which usually contains ethambutol, we usually request them to avoid ethambutol to reduce ocular toxicity, because it's already an inflamed eye, on top of which ethambutol toxicity can happen, and so we request them to avoid ethambutol and request for levofloxacin. This is all not given in book. This is, I am telling you for practicality purpose. The newer regimen, they have already converted ethambutol to moxifloxacin, so which is relatively a less ocular toxic regimen. So in this patients, we start when ATT goes on alone, the ocular inflammation will increase. When anti-inflammation alone is given, anti-inflammatory like oral steroids alone is given, the systemic tuberculosis will increase. So both has to go on simultaneously. Okay, so why oral steroids? Why not topical? Anything behind the lens, it needs to be oral works better. Topical has not much of a role. So we give oral and systemic treatment together in case of ocular tuberculosis. Okay, so moving on to next thing, choroiditis. Already I have shown you how a choroiditis looks, which is the lesion which is underlying the blood vessel or underlying the retina. I'm sorry. So how do choroiditis lesions look like? So in the first picture, if you see, these are 2 choroidal tubercles. So 2 choroiditis patches which is little raised. So you can call it tubercle. The second one is multifocal choroiditis. You have more than 1 foci of choroiditis, which is called as multifocal. When you have choroiditis which is diffuse, patchy throughout, you can call it diffuse choroiditis. So the other one is, look at this. This is a geographic patch which is just in the peripapillary region. It is called as GHPC, geographic and helicoid peripapillary choroidopathy. It was previously called as serpiginous choroiditis. Okay, so serpiginous, snake-like margins. So when you have an active lesion will look like this with a fluffy margin, no clear-cut boundary. When it gets healed, you get a clear-cut boundary. So when you start the patients on the treatment, which is either IVMP or oral steroids, what do we look for? We look for the margins getting clearer, the boundaries getting clearer. Okay, so in this patient, because the macula is involved, so when this sort of an uveitis comes to us, the macula the fovea is getting threatened, so we treat it with a stronger steroid, which is basically intravenous methylprednisolone, and or else we could have just started oral steroids per se if the fovea is not threatened. Okay, so depending on the inflammation, depending on the severity of anti-inflammatory therapy required, we decide what sort of treatment we want to give for the patient. So and this is another these are other terminologies, like see, the first picture is a small tubercle or a nodule. Nodule is even much more smaller. So tubercle is this is a choroidal tubercle. When it is raised, we call it a choroidal granuloma, and even when it is further raised with a lot of subretinal whitening, we call it abscess. So this is the gradual progression of a lesion. So you can call, you need not have all the same thing in the same patient, but this is a we can say it is like a sequence in which it can progress if you don't treat it and if it worsens. So this is a subretinal abscess or a or a choroidal, a large choroidal granuloma with the subretinal thing on an OCT. So this nowadays we treat with intravitreal moxifloxacin along with an anti-VEGF. So this is like when apart from your ATT and apart from your oral steroids, when the inflammation is very severe and when we want the drug penetration to go into the granuloma very fast, so we give anti-VEGF with intravitreal moxifloxacin. So moxifloxacin is the actual drug. It penetrates into the granuloma and it reduces the bacterial load per se. Okay, so this is status post injections, and you can see that it has regressed. Okay, so it regresses and it becomes a scar. So choroiditis, the spectrum of choroiditis, you can see PIC, APM PPE, amphigenous choroiditis, multifocal, serpiginous and serpiginous-like. So these are different types of choroiditis. It is named based on how the patches look, how small, or what is the pattern of patches. So punctate inner choroidopathy, PIC, is punctate lesions seen mostly, if you want to converse, it is only choroidopathy. There is no there is no or very minimal retinal association. You do ICG for the patient to look at those hypocynosine dots. The lesions in ICG looks hypocynosine, which is black. So black rounds, that is how it looks. When there are little larger lesions involving both the outer choroid or the choriocapillary layer and the outer pigmentary epithelium, it becomes a lesion like this. So this is called APM PPE. So when these lesions also become even more larger, and it is called as amphigenous choroiditis. And when it becomes even more larger, you can call it multifocal. When these lesions coalesce to form a lesion, it is called serpiginous choroiditis. So a patient need not always present in this classical manner. I am telling, a patient can come straight with serpiginous like choroiditis. It need not always be starting from PIC, APM, PP, gradually progressing to this thing. But the patient will have problem even from the initial stage. So this is a spectrum of disease. So serpiginous like, yes sir. So these are all distinct entities. They can present as themselves, like PIC the PIC presents as PIC, and it does not usually progress to the next form. So it can present as individual entities. But for our understanding sake, we understand it as a spectrum of disease which has similar treatment modalities, which require similar investigative modalities and such. So serpiginous like choroiditis is where you have a serpiginous lesion and you have few satellite lesions away from those which hasn't coalesced with the main lesion. Okay, so and coming to white dot syndromes, these all have been classified as white dot syndromes. APM PPE, PIC, birdshot chorioretinopathy. We have something called as mutes, where it is an evanescent lesion, which is self-limiting condition where the lesions occur. During that time, patient says, yes, my vision has diminished. And then after a few days, it vanishes by itself. You need not have to treat the patient. You just have to observe, document. You imagine you find a patient, you look at those lesions, patient is telling diminution of vision, you document it using a FFA, and 10 days later, even without your treatment, everything becomes all right. So that is called, that sort of a lesion is called mutes. And you also have multifocal choroiditis, GHPC and POHS, which has been classified into the same has been classified into the same category as white dot syndrome. White dot syndrome by itself is a separate class. Till now we have spoken about choroiditis. So now coming on into a lesion where both choroid and the retina is involved. So when the classic retinochoroiditis is usually toxo. Toxo is usually at the macular region affects the macular region. So it is a parasitic infection which typically is in the posterior pole, but it can also occur elsewhere. So when it occurs in the posterior pole, it is called as typical toxoplasma. When it is outside the macula, it is called as atypical toxoplasma. How do we, this has a typical, the first picture, you look at it, it is like headlight in fog. So this is a very classical picture which they show you in exam as a spotter, which is headlight in fog appearance of a Toxoplasma retinochoroiditis. So how do you confirm? You confirm its clinical diagnosis, but you confirm using ELISA from blood or from ocular fluid. So the treatment is basically pyrimethamine, sulfadiazepine, and with clindamycin. And this is the antibiotic, and along with that you give oral steroids to reduce the inflammation. Nowadays, when you see active toxoretinochoroiditis, we give intravitreal clindamycin because in most of the, as I said, it is macular involving. So we need immediate results. So we have seen intravitreal clinda doing a better role. It is only a top-up and it is not a replacement to the classical treatment. So for exam going, I am telling, if they ask you about anti-toxo drugs, you have to list a name of all the drugs. Even if you don't write the dosages, it is fine, but you need to mention all the drugs. The drugs that I use which I have seen people more using is actually the drug number 3 and drug number 2. Drug number 2 is clindamycin 300 mg 4 times a day, and the other one is trimethoprim with sulfamethoxazole double strength, which comes as Bactrim DS or which comes as Septran DS. Okay, so when clindamycin is when the patient doesn't tolerate clindamycin, we shift to azithromycin. And in special situations, like in cases of pregnancy, we use spiramycin. So the second picture here is an active toxo. The first picture here is actually a scarred toxo. So the treatment for a scarred toxo is nothing. You just observe. If you want to confirm the diagnosis, you can do an ELISA. But if you it is not going to, we are not going to treat the lesion per se. Coming on to the retinitis proper. Retinitis is only the retina, the inflammation of retina alone. So this lesion will be entirely white. You will not see anything in the lesion, but you can have associated vasculitis, which is the vessels in the retina. Along with the retinitis, the surrounding retina can have bleeding and hemorrhages. So the first one is actually a CMV retinitis, which is a patchy retinitis. The second one is acute retinal necrosis, which is a white lesion in the periphery, and third one is progressive outer retinal necrosis, which is ARN and PORN. ARN occurs in immunocompetent patient and PRN occurs in immunosuppressed patients. So ARN is actually a peripheral retinitis. It becomes circumferential. There is a circumferential spread which is noted. You have hyperemic optic disc. You have vitreous opacities because the patient is immunocompetent. You have occlusive vasculopathy with arterial narrowing in the nearby area. Whereas in progressive outer retinal necrosis, you have peripheral retinitis without much of macular involvement. There is no consistent spread like circumferential. It can spread into the eye as well as circumferential, and it can have patchy places also. It has a classic crack mud appearance. It came for my ASCII question, crack mud appearance, and there is minimal or no ocular inflammation when the patient is immunocompromised, and there is absence of inflammation mostly, and so this is the difference between ARN and PORN. Retinitis is usually viral. It can happen through HSV, VZV, or CMV. So in these lesions, because the retina per se is involved, there is high risk of retinal breaks or detachment. So hence we need to have a very close follow-up of in these patients. In ward duties, you would have seen patients of retinitis getting admitted for days together, 6 to 7 days or more than a week, usually in VG block. So if you have seen those patients, you can, usually these patients get dilated every day. You can go and have a look to see how a retinitis patch looks. Okay. And usually every day the fellows or whoever they come, they see these patients because these patients have a risk of developing retinal breaks and detachment during the course of the process. So usually these are treated with antivirals. They are admitted in the ward because they need antivirals in intravenous method 3 times a day or 3 times a day. So what is the usual thing, which is 500 mg 8th hourly acyclovir is given for 2 to 3 weeks, followed by a maintenance. When we shift from intravenous to maintenance, we shift it to oral and we send the patient back. So we start along with intravenous acyclovir, we do give oral steroids 3 days or 2 days after we start the antivirals. Okay, inflammation reduces, but steroids alone is not the treatment. Okay, steroid is an additional thing which we give to reduce the inflammation. But starting oral steroids alone in such a patient would be deadly because virus will worsen the lesion. Okay, so antivirals are the first treatment, and later on you can give steroids when things come into a better control under the viral cover. So CMV retinitis, we give intravenous GAN cyclovir, followed by maintenance we convert it to Valgan cyclovir, and in intravitreal GAN, we also have intravitreal GAN cyclovir, which is given to lesions when it is very close to the fovea or fovea threatening. We have another group of retinitis which is called as post-fever retinitis. The history itself, from history you will be able to find the patient would have had some fever. So at that time we should be at least having what fever they were worked up for previously, or we work up for most of the fevers and we find what is causing this sort of retinitis. Usually these sort of retinitis do not require full dosage of full-fledged immunosuppression. They are usually immunosuppressed for a little, depending on the lesion. We give half dose, or 0.5 mg per kg body weight, or we sometimes, when the lesions are very, very less, we even tend to observe and wait for the lesions to resolve by itself. So another thing is syphilis. Syphilis is again, you would have already known, it's a great masquerade. It can have various presentation. One presentation that it shows is punctate inner retinitis, these lesions, white dots in both the eye with a ground glass background. So syphilis can even present as pan-uveitis. The important thing is history taking, sexual history of multiple partners, and the test would be VDRL and FTA-ABS, or because one has a better sensitivity, one has a better specificity. The treatment is injection penicillin. So this is a gist of whatever infectious things that I would like to tell. I have told it to you. The autoimmune diseases includes the more common that we see are SLE, granulomatous polyangiitis, and granulomatosis with polyangiitis is also previously called as vaginous, and then polyarteritis nodosa. So this is an SLE patient. SLE like classically what we see is a malar rash, and a patient presenting with a malar rash, or who has been referred by a rheumatologist who is a known patient of SLE with ocular lesions. Okay, when when a patient of SLE has ocular lesions, that means the disease is an aggressive disease. SLE usually always doesn't present as an ocular disease. So when you have an ocular lesion of SLE, it means the disease is aggressive and it needs to be treated aggressively. So this is SLE retinopathy. So there is a 32-year-old patient who presented with blurred vision and redness for 1 month. She had stiffness, history of stiffness 6 years ago with malar rash which subsided, and history of 4 years of SLE, who was on HQQ treatment, who had a diminution of vision. So she had presented with lesions like this, and right eye diminution of vision is because of the macular edema which was noted on OCT, and the patient blood test revealed that ESR is raised and it came positive for ANA. So when you have such a vasculitis, you have lot of CNP areas, which is capillary non-perfusion areas, noted on both. This is an OCTA picture, okay, not an FFA picture. This is an OCTA picture where you see the capillary non-perfusion areas for which the patient got lasered. Okay, why laser? Because it should not progress into the vascularization, it should not develop neovascularization. So they had given the laser. So as I told, this is an aggressive form of a disease. So it was treated with rituximab, which is a biologic, along with oral steroid and MMF, and later on tofacitinib was also added. So it was a combination of biologic, oral steroid and an immunosuppressive therapy. Okay, so before rituximab was invented, these patients were managed with IV cyclophosphamide. So this is one example of an autoimmune disease, which is a very common question, which is SLE retinopathy. HIV retinopathy is another question, which is mostly microangiopathy, which is an ocular manifestation which is associated with low CD4 counts. So this microangiopathy occurs due to the viral per se, and they can have associated cortical wound spots with intraretinal hemorrhages and microvascular leakage. There are a subset of patients which also have RNFL thinning, which has been noted. So these patients at this particular stage are usually asymptomatic unless and until they have anything close to their fovea. They are mostly asymptomatic. But this is just the HIV retinopathy. Along with this, when opportunistic infection presents and when that involves the eye, the presentation differs. The same Toxoplasma choroiditis, when it happens in a immunosuppressed patient, it presents with a varied presentation. It is more aggressive. It looks like a big retinitis patch, not like the classic headlight in fog appearance. So there is also a risk of other opportunistic infections in HIV. So when these patients are started on the antiretroviral therapy, which is the HART therapy, they start manifesting inflammation against these opportunistic infections which have already encroached into the eye and the features according to the lesion. So ocular sarcoidosis is another thing where you have classically seeing granulomatous capes, peripheral anterior synicase, you have candle wax dripping, you have enlarged lymph nodes in the chest noted on HRCT, you have lymph nodes elsewhere in the body, and on histopathology you will have non-caseating granulomas. So Behcet's is not a classical posterior uveitis, but it is mostly a pan uveitis, and when it in the posterior part of the eye, when you do FFA, you see ferning pattern in the FFA. There is ferning pattern of leakage, which is noted in the FFA. So this is very classical of Behcet's, but it does not, this per se does not give a diagnosis of Behcet's. So you look for other features like erythema nodosum, oral ulcers, genital ulcers, and Behcet's is, again, as I said, it's a pan-uveitis. All pan-uveitis does not actually present in the, as pan-uveitis to us. In the initial stage, they can present as anterior uveitis alone, then becoming pan-uveitis, or posterior uveitis alone, then going into pan-uveitis, or pan-uveitis itself. So if you see, there are 64% of the patients of Behcet's who presented as posterior uveitis, and it has a male preponderance. And since it is a pan-uveitis, patients are treated, there are few patients who got treated with steroids and immunosuppressive with biologics. Okay, and there are also equal set of patients who got treated with steroids and immunosuppressives together, because we know Behcet's is a pan-uveitis and it needs aggressive management. So if you look at Behcet's patients with biologics, they have done very well. Meaning, if you treat it aggressively, the end results, they give a better visual prognosis. So this is something very similar. You have these, the entire length of the retinal vessels having sheathing, right? But this is not what we talked about before. This is not Behcet's. This is just frosted branch angiitis. The entire, how a branch of a frosted, how it is, the entire branch is looking like a frosted thing. Okay, so this is frosted branch angiitis. This is not a disease per se. This is just a sign. So when you have this sign, it means the disease is very aggressive. That's it. So the treatment needs to be aggressive. Any disease can present with frosted branch angiitis. TB can present as frosted branch angiitis. Syphilis can present as frosted branch angiitis. SLE can present as frosted branch angiitis. So that is not a disease, that is a sign. And another thing which is an important exam question that PGs would like to know is IRVAN, idiopathic retinal vasculitis, aneurysm, and neuroretinitis. Usually we see lot of exudates surrounding the capillary loop, which is usually at the optic disc. Okay, and there are lot of exudates around. So it is of unknown etiology. Usually affects young healthy females. Inflammation of the retinal vessels is associated with the ocular inflammation. Perifibrillaritis is more common than arteritis. So the patient has large capillary non-perfusion areas with macular exudation, and SSOCTA is the current non-invasive investigation of choice. But if you don't have a wide field SSOCTA, FFA is still the best option. So the first picture is an FFA picture showing anything beyond this is black, which is completely ischemic retina in both the eyes. So similar picture in SSOCTA, you see these are the probable CNP areas. So the CNP area is also merged with the norm. This is a normal avascular zone. So here the avascular zone has merged with the CNP area. So here if you see in FFA, the picture is even more clear. Okay, so FFA picture gives you a better delineation for before doing the full field, the laser, because if you don't laser in for a large CNP area, the risk of neovascularization is fast and more. So what can happen in any posterior uveitis? The lesions can scar, it can fibrose, it can develop a CNVM, because the inflammation, when the inflammation leaves, there is a residual damage that happens in the natural part of the retina. The normal anatomy is altered and is disturbed. So starting from not just visual loss, starting from visual field defects, it can range from the lesion becoming into a scar, it can have fibrosis, it can develop a CNVM, there can be retinal vein occlusion beyond the area of inflammation, which is noted as hemorrhages. It can have, the patient can, there can be disc edema along with the uveitis. The disc edema can be only because of inflammation in the surrounding areas. It need not be optic neuritis per se. It can be a pan-uveitis having a disc edema along with that. And there can be neovascularization elsewhere meaning in the retina or in the disc or even in the iris. There can be tractional retinal detachment. There can be retinal breaks or holes. There can be chronic macular edema. There can be formation of an epiretinal membrane, which is also a form of fibrosis which develops over the retina. Because of the ERM, there can be a macular hole or a lamellar or a full thickness macular hole because of the tractions caused due to the fibrovascular proliferation. There can be cataract, there can be glaucoma. It is just like telling complications of any drug, which is basically nausea and vomiting. And this eye can go into phthisis when you left it untreated in any pan-uveitis. Okay, so when you look at any lesion, only when you know your knowledge is what tells you what you can see. If you don't know something, you will never see it. If you know, you have to look for it. Only when you look for it in the eye, you will see these lesions. The more the time you take at looking at these pictures, when a patient present to you with some symptoms, all these patients will present to you with diminution of vision and blurring. When there is associated vitritis, they will have floaters. Otherwise, they will not have floaters. When these patients will not have redness and pain unless and until the inflammation has spread into the anterior chamber and it has been there for a long time. Understand? So inflammation, just like I told, when you have an injury to a place, the surrounding area also gets inflamed. So in the posterior uveitis, when there is vitritis and when you don't treat it, there is spillover anterior uveitis. There is spillover optic neuritis. The disc gets sedimentous. There is when there is, it can spread into a pan-uveitis. Understand? So a posterior scleritis can have an anterior spread. It can have anterior scleritis as well. And anterior scleritis can spread posteriorly as well. So you will have to look for these lesions. You will have to look for the surrounding spread and surrounding inflammation. So this, and the history is very important. This, what does this look like? It looks like a choroiditis, or it could be a multifocal CSR. Just because you come into Uvea doesn't mean retina doesn't exist. No? So it can be a multifocal CSR with fibrin. It could be anything. So you did ultrasound. In the ultrasound, there is a retinochoroidal elevation with a early subtene and widening. Okay, I'll tell you the history of the patient. Patient comes with pain on eye movement and diminution of vision. Classic posterior scleritis. But if I don't tell this history, this same picture can be choroiditis picture. It can be CSR with fibrin picture. It can be anything. So ask history. Then do your tailored investigation. So this is a OCT picture where there is the inflammation is so severe, the posterior scleritis is so severe that there is intraretinal fluid accumulation. Okay, and because of that there is a CNVM. Understand? So the complication, the disease per se is something. It has not been treated for so long, and then because of the aggressive nature of the disease, it has developed a complication which is completely unrelated to it. Understand? This looks like a multifocal choroiditis, but it is actually a intraocular lymphoma. So these sort of lesions are called as masquerade. Masquerade lesions itself is a class per se. Toxocara. Toxocara is something like, it's a zoonotic infection occurring because of parasites. So it can present as granulomas either in the periphery or at the optic disc. Usually it is in the peripheries. So the granuloma along with the retinal fold. So these sort of peripheral toxocara granulomas, when there is no surrounding inflammation, you don't treat. You just note it and you leave it. Unless and until there is some other complication which is causing, having any vision threatening thing, or when there is inflammation, you treat it. Otherwise, you don't treat. This is DUSN, diffuse unilateral. Anybody knows? Okay, this is your homework. Go and read. So, any uveitis, take a proper history, do a proper ophthalmic examination, which means from slit lamp, starting from cornea, not till the lens, it is beyond the lens. Look into the anterior vitreous face to say if there is vitreous cells or not. Without AVF, you will not have the complete picture whether vitreous has inflammation or not. Okay, you can look at the vitreous cells on a slit lamp. You can only, if you look through an IDO, it will only be a haze. And when there is a mild haze, you tend to miss. The patient will tell, I am having floaters. But you will say, normal. No, it's not normal. You will have to look at the anterior vitreous face in a slit lamp and compare that with the amount of haze that you look on an IDO. Okay, and then you do a tailored investigation. You should know the etiological classification to know what investigations you need to do, and then you can manage. Okay, so it is very important to differentiate between non-infective and infective, because the management itself is very different. That you should be judicial in using FFA ICG, your investigations. You cannot jump directly into invasive investigation when you have multiple non-invasive things which are available. So use your investigations judicially, use your drugs judicially. You can use systemic steroids and immunosuppressive, and you cannot use immunosuppressive for all patients, or you cannot start oral steroids without knowing whether it is infective or non-infective. So all these uveitis, because they cause permanent scars on your retina or in the posterior pole, and it affects your vision, you all treat these conditions as ocular emergencies. You see it in emergency and send it to Uvea E, because they are emergencies. Understand? The earlier the treatment, better is the prognosis. Thank you. Any doubts? Any questions? This was a very broad class. I tried to cover most of it possible. Thank you.